Hey, what's up, everybody? I'm Maggie Reichard, and you are listening to Nursing Uncharted, a podcast designed to help you discover uncharted territory in nursing. Thank you so much for listening to us this week and every week while we talk about different specialties and uncover their stories and experiences. This episode is a part two of an operating room series that we started a few weeks back with episode 11, where we had Andrea Dyer, a pediatric travel OR nurse, talk to me about the ins and outs of the OR nursing realm and also advocating against bullying in the workplace. This episode shifts our focus to another hot button issue within the OR setting, and that is the presence of surgical smoke. We will talk about what surgical smoke is, how it affects us, and what we can do about mitigating those effects in our respective facilities. So, here to shed some light on this topic is Vangie Dennis. Vangie is the Assistant Vice President for Perioperative Services at ANMED, a third designation magnet facility located in Anderson County, South Carolina. Vangie is currently president elect for the National Association of Perioperative Registered Nurses, or AORN. Her professional affiliations include AORN, American Organization for Nursing Leadership, or AONL, Laser Institute of America, and the American Society for Lasers in Medicine and Surgery. She's on the editorial board for the Journal for Clinical Laser Medicine and Surgery, OR Today, and Outpatient Surgery. Vangie is on the board of directors for Laser Institute of America, the chair for the National Certification on Lasers, Board of Laser Safety, Board of Commissions, and representative for the American National Standards Institute. She's a recipient of numerous awards and recognitions and a member of the Emory Alpha Epsilon chapter of the Sigma Theta Tau International Honor Society of Nursing. So, Vangie, welcome to the show.
Oh, thank you, Maggie. It's an honor and a pleasure to be able to talk in detail a little bit about what we're subjected to in the operating room.
Yeah, I mean, it's such an honor to talk to you today about this
Yeah.
issue, and something that you're so well versed and passionate about. I had a great conversation with Andrea, so I'm so glad that she steered us to you today to
Well,
talk about this.
but you're welcome. But a lot of people have a misconception of surgical smoke, and sometimes it's referred to as plume.
Mm,
It depends on what professional organization. You've got the International Council on Smoke Plume, but anything that generates that vapor. But
mhm,
we're very familiar with the word smoke, so you're going to
yeah,
see that autonomously used with plume, and even in the NIOSH overview that we sent out through the Association of Perioperative Nurses, we refer to it as smoke because that's
okay.
the common nomenclature. But
Sure, sure.
you know,
Okay.
I'm sure you're probably going to ask me what is smoke, and it's exactly what you're used to, whether it's cigarette smoke or fajita smoke or you're out there grilling a steak. It's smoke. But how we control bleeding in surgery
Mhm.
is with heat generated devices, and the
Yes.
byproduct, just like cooking a piece of meat, that sounds pretty gross. The byproduct is smoke,
Yeah.
and that's what the byproduct is of actually controlling that bleeding is
Mhm.
heat generation, and the byproduct is human body part smoke is what it
Right.
is. Yeah.
Yeah. So, and the types of procedures, I mean, when I think of, so a lot of nurses don't generally think of surgical smoke in their other outside of the OR,
Right.
but except sometimes you'll be in procedural areas or, myself, I'm an ICU nurse. And so sometimes we'll have endoscopy, GI come up and do an endoscopy or
Yeah.
something. And we might be exposed to some of that cautery, in the room itself. So I just want to kind of start with the very basics, like you were talking about, just to kind of get a sense of, what we are talking about here. So, what are some of the different surgeries, I guess, that would be more high risk for, those type of, that require that use of heat device?
Well, if you think about heat generated sources, and that's the cautery or the bovie or the electrosurgical unit, it could be lasers, it's anything that produces heat when it impacts tissue.
Mm,
And you say, well, what are your high risk procedures? Well, 98% of your procedures use generate some type of smoke.
right.
98% of what we do.
98%.
And when you look at the byproducts of that, what is high risk? It's kind of like, well, can you hurt yourself with a shotgun if you shoot yourself? Can you hurt yourself with a regular 45. It talks about the exposure time, and the amount of smoke that's produced in the case can vary for
Okay.
case to case. So is one more high risk than the other? The constituents of surgical smoke are the same, whether it be a 5-minute tonsillectomy or a 3-hour reduction or breast reduction or hernia repair. You're just going to
Mm,
have more exposure because those procedures generate more smoke, but one is no less detriment for the exposure of our team than the other. And I think that's real
mm.
important take home.
Yeah, really, because you would think the amount of time would be a factor there, but it's really, the surgery itself or just the being exposed
Just
at such like a
Yeah,
rapid
just
rapid
being
rate.
exposed. Maggie, that was a good point, which helps me clarify it a little bit. It is the amount of time, but it's
Mm,
the time that the nurse and the surgical tech are in that operating room. And there may be a run on an 8-hour shift, just like ICU nurse. You have about hopefully 8 hours worked in today's COVID world. Um, but we're in there 5 to 7 days a week.
right,
Where your
right.
surgeon may have a run or may have a block 1 to 2 days a week, our exposure rate for CRNAs, anesthesia, or PAs,
Yeah,
AAs, whatever you have in your hospital facility, the circulating nurse, the scrub tech, we're exposed at a much higher time rate because we're in there all the time.
right.
Mhm.
That is, I mean, it's amazing, and I want to get into, exactly like what the effects of surgical smoke are
Sure.
because that's what I was, really interested in thinking of all the people that are in there day in day out.
Mhm.
I was reading through one of these presentations that you give nationally and some of the facts about surgical smoke are so startling.
Mhm.
I mean, just I was reading just 4 to 6 hours of being in the OR exposed to this smoke equals like 27 to 30 cigarettes or
That's
I
correct.
mean, so speak to some of the, the worst harmful effects that are coming of producing surgical smoke.
Yeah, yeah, you became well versed in that. We've done research since early 1985 when NIOSH did some of the initial studies on surgical smoke, and nothing's really can't changed. We can research and research, and I mean, we have up to date research 2020 and 21.
Mhm.
You're not smoking filtered processed tobacco, and this is not a judgment call on cigarette smokers, but you are processed filtered tobacco, and what we are smoking is the byproducts of human body parts, no matter
Mm.
whether it's a hernia repair or whatever. The constituents of the carcinogens are more mutagenic than what you get in a cigarette smoke. Now, not even talking about the
Mm.
transference of viruses and bloodborne pathogens and other particulates. You have over 140 to 150 different chemicals depending on the type of case we're doing. And those chemical levels
Mm.
are things like formaldehyde, benzene, and those are the carcinogens, not including the high risk of the viruses and the bacterias. You have so many different sizes of particulates, but
Yeah.
the heat generation, unlike a cigarette, vaporizes small particulates, and
Mhm.
the smaller the particulate, the further that smoke will travel or aerosol in the room. So they are as small as zero point 0.1 microns. What
Right.
does that mean? That particulate is small enough to get in the alveoli of your lungs, and
Yeah.
the transference is very, very similar to that of cigarette smoke. It goes to all parts of the body.
Yeah.
I want to pull some because I definitely don't want to misquote it. And it just, even in my own lectures, it surprises me of some of the impact of that surgical smoke.
Yeah.
And I wanted to pull that research up. I should have had it ready.
I was reading, I mean, it passes through not only the alveoli, but the placenta, I mean, the
Yes, it
lymphatic
does.
barrier, just I mean, so you are exposed to your whole body is exposed when you're producing that
Absolutely.
in the room.
And what do they tell female that's pregnant is don't smoke cigarettes. So I'll give
Right,
you an example of the particulates and how much gets inhaled. And we're talking about maybe one surgical case. Remember, we're in there 5 to 7 days a week, all day long.
right.
They're in there, do the case, and they leave. There is what we call particulate counts. And remember, I said these particulates
Mhm.
can be large dust as small as zero point 0.1 microns that go
Mhm.
deep into your lungs.
Mhm.
A count on a standard incisional hernia repair, most of us know what that is if you're in healthcare, has
Mhm.
292,000 per cubic centimeter for an incisional hernia repair of particulates. And that is not isolated to those individuals at the surgical field, but it
Right.
aerosols and can travel throughout the entire operating room, even into the air vents that can go into the hall of the OR suite. A liver
Mm.
resection has 490,000 cubic centimeters of particulates. And then
Mm.
the average tidal volume when we breathe in is 500 cc's during an incisional hernia repair, which means the surgical field or the individuals in the surgical fields breathes in, you're going to die. 146 million particles per breath, and 70% of those are less than the zero point 0.3 micron size.
Oh my god.
So not only do you have all the same effects that cigarette smoke has, only 1 gram of tissue vaporized by a, a, a CO2 laser, or which is a common instrument we use, is equivalent to smoking 3 unfiltered cigarettes, not including the bloods and the viruses and everything else that are transmitted through there. But 1 gram of tissue by the device we use in 98% of our procedures, the electrosurgical unit or cautery,
Mm.
is equivalent to smoking 6 unfiltered cigarettes. So
Wow.
we're talking a gram, which if I did this is probably that big, and we're
Yeah.
breathing it all day. And I think what's happened with us in healthcare, remember bloodborne pathogens. I don't know
Mhm.
if I can remember 25 years ago, nobody thought anything about getting splashed with blood. That was your badge of honor as a surgical nurse. You got to come out with blood on your outfit
Yeah.
here. And now we're PPE and all the
Mhm.
COVID and SARS and tuberculosis and how important PPE is in every area we work in nursing. And then ergonomics came with patients of size and nurses and surgical
Mhm.
techs and everybody was pulling out their backs, and we got
Right.
hover mats and all this stuff for
Yeah.
transporting patients from bed to stretcher and vice versa. But why are we taking so long to put in safety devices? And then not patients, staff was coming down with a nonspecific lymphoma and leukemia due
Mhm.
to not having scavenger systems on the anesthesia machines because the constant exposure to the anesthesia gases. And lo and behold, DNV and Joint Commission now says you will have scavenger devices on there to
Mhm.
protect the staff because this
Mm.
is exposure is really not good to see those anesthetic gases all coming
Yeah.
and smelling it. I can even remember almost falling asleep in my earlier years as a nurse because there was no scavenger
It's
system.
like everybody has to be on their game when they're doing
Yeah, yeah,
surgery, let alone what is
yeah.
a scavenger device
It's
specifically?
it's on the anesthesia machine, and we have all types of anesthetic gases that put patients to sleep, and it keeps the leakage at a minimum exposure to the staff that are always in that room. So
Okay.
we implemented all these safety devices, and here we've been using surgical devices to vaporize tissue with Dr. Bovey and Dr. Cushing for years, and we or like the other protective equipment, we didn't think anything of it. And now it's all
Mhm.
coming to fruition that through research we found out how
Yeah.
bad it is for us to smell it and be exposed.
We want to take a quick break from this episode to talk about the industry leader in travel nurse staffing, American Mobile, combining the largest network of facilities and providers in the country with top level benefits like higher earning potential, premium health insurance, and 401k matching. American Mobile puts you in the driver's seat of your travel nursing career. Make sure to visit AmericanMobile.com today to discover a world of adventure with American Mobile. That's AmericanMobile.com, the first step towards your next travel nursing adventure. What do nurses and OR staff say? I mean, what's their reaction when you tell them, this with this information? I mean, is there how have we not combated this yet? I feel like I mean, but like you said, it's just things come to fruition and then it takes time, but I mean, we've just been I feel for all of the OR
Mm,
nurses, and the staff that has probably
mhm.
had chronic illnesses or asthma or, however it's affected them long term.
I think it's come to visibility over 20 some years of research, and now we're seeing the repercussions. At the Georgia Council of Perioperative Nurses, we held a conference that specifically addressed air quality in the OR, including surgical smoke. And Angela Holmes was and actually she worked with me at Gwinnett years ago. She had stage 4 lung cancer directly
Mm,
associated with the exposure to the surgical smoke. So we're
yeah.
hearing and now seeing validated research over cumulative years. And I think that's the passion and the fight nurses and techs are doing today to get law passed.
Right.
So the first thing they say to me is, why do we need a law? Why don't we just use it? Because it's, I say this respectfully, the OR is a revenue generating service line,
Mhm.
and it usually caters to what the physicians are comfortable with. And
Mhm.
you can't mandate something unless it becomes law. It is like what Joint Commission does, even though they're not regulatory or DNV. But if they say do it or CMS says do it, we better do it. So I think pushing those regulations, recommendations will come, and it's starting to come
Mhm.
state by state. There's, I think, if I think about it, there's Denver, not, excuse me, Colorado, Oregon, Rhode Island. I'm trying to think. I think there's 4 states or 5 states now that have law passed on this, but
Okay.
but that was a big, big focus no more than a month ago
So
at
what
the Georgia
what does
Council.
the law what's in that bill? What's in the law that
Mhm.
what are we regulating to what extent?
We're not, the law is not saying, how you hook up. That's clinical decision because there's
Mhm.
multiple means of decreasing potential exposure. But the law is saying you will use local exhaust ventilation. And some of the counter
Mm.
argument is the air exchanges in the room, which in an operating room or procedure room should be 20 to 24. That air exchange is not enough to bring it to baseline levels contiguously. That is that
Mhm.
misunderstanding. So we've got to convince them that wall suction does not do it, nor does it have enough
Mm.
pull to capture the viruses and the blood and all that aerosolization that occurs with it. So the law will say use local exhaust ventilation and enforce policy compliance and policy um, to put a policy in place at the institutions. So if you got a policy, you got to abide by it. So it's more
Okay.
forceful than just recommending a guideline.
I see, I see.
Mhm.
What has been, some of the biggest barriers, I guess, for implementing some of those measures to mitigate smoke in
Mhm.
facilities?
Surgery is got a culture or a rhythm. And
Mm.
I've been smoke free in all 5 institutions over 25 years without law. And my take home is don't interrupt the culture of surgery. It's kind of like getting in your car.
Mm.
Yeah, you put a seatbelt on, but it's not a guarantee that everything is going to be perfect. Surgery itself is an inherent risk for us that's in working or scrubbing. You can stick yourself with needles and splash yourself and smell smoke. So I think the biggest thing is when we implement a change is to involve your physicians and your nurse and tech champions in
Mm.
learning how to hook up appropriately so you still are in the business to do surgery safely, because
Right.
everybody comes up and wants to hook all this stuff up. In the meantime, the tool becomes worse than the disease and you can't treat the patient.
Yeah.
So good practices for hookup. Make sure that we can still do the surgery with it not weighting down the delivery device or the pencil, because everybody starts putting the stuff on the pencil. There's all kinds of creative ways, but the take home is don't interrupt the culture of surgery. And it can
Mm.
be successful. We converted in 60 days at this last hospital I was here.
That's amazing. Oh my
Mhm.
gosh.
Yeah.
So essentially, we are holding ourselves back by being reluctant to change in a sense because of the culture that,
Yeah. It's a
tough
cultural
it
thing.
out and,
Yeah.
that kind of thing.
Absolutely.
We're talking a little bit about solutions, but what specifically solutions are in place to create a smoke-free environment?
That's I always call that the $50,000 question. And,
Yeah.
and you saw that in my presentation. It's how do you implement smoke evacuation processes? And there is a sequence of events for implementing that process. First, you definitely, if we don't think we do, have to get administrative support, and that means financial support. And I definitely include my infection preventionist, maybe my safety committee, and then the choosing of physician and nurse and tech surgery champions that believe or are passionate about it. I always try to do a pretest or a gap analysis to see what is the reluctance, because it's been out there for a
Mhm.
while. And that way, you know how to educate our surgeons and our staff. I make sure that there is evidence-based, substantial resources within the last 5 years, because I could bring a resource paper to one of the docs that's 20 years old and he's going, well, has anybody really ever proved this?
Mhm.
The other thing is I never force product. And most companies are
Mhm.
very aggressive. It's not that expensive. I think a Bovie pencil is $22 and a linear cutter is $600. Okay,
Mm.
not that one is more important than the other. And the corrugated tubing they use to connect to the machine is $5. So I do it
Mm.
what they call a tabletop. I don't force product evaluation on our surgeons, because you
Okay.
go in a room and they've never seen this and they go, "What the heck? I'm trying to do surgery here, guys." And then I it
So
make
is it
sure
the products themselves that eliminate that smoke then, or is it localized vents like you said, or is it a combination of both?
it's a combination of both. You have a
Okay.
local exhaust ventilation, which is a machine that filters down to the point 0.1 microns, and then has what they say what we
Mhm.
call a cubic foot per minute pull of up to 70, where wall suction's only 5. So you got to have that pull. You got to pull it out of the way. Not
Yeah.
only filter it down, but you got to pull it out of the way. Then you got to
Mhm.
have disposable devices that connect to it that capture the smoke. And
Sure.
there's something as simple as I don't know if you've ever seen anesthesia tubing. It's about 1.5 inch diameter and corrugated, and that creates what we call a vortex for removal. But you also have
Mm.
smoke evacuation capture devices on the Bovie pencil.
Okay.
Or you have a telescoping connectors to the Bovie pencil, so it gets right at the site. Well,
Okay.
that's the doctor's pencil. That's their surgical device that they
Right.
use, and I can't tell them what they're comfortable with or what they're
Yeah, they're
not.
not gonna give that up easily. Yeah.
No. So we let them choose, and by doing that, we set a tabletop up. And that tabletop helps them play with a lot of this stuff before they use it on a patient. Then we did
Mm.
something kind of creative. We hooked up like a point 0.1 micron. Remember, these viruses and particulates are very small. And
Mhm.
we put these inline filters between the wall suction and our suction canister. Now,
Mhm.
that doesn't mean it captures the virus, because the flow of the wall suction is only at 5 cubic foot per minute. But doing
Mhm.
that, we can at least, like you said, when in ICU, when you're doing GI cases where you get small puff of smoke, it will capture that.
Okay.
And then when you get everybody on board with all this education, we set a go live date, and that's what we did. And then we monitored the practice, and then we post tested them again. We said it's not a pass or fail, but you could see a significant difference when the education was delivered. And after we've done all that and people get comfortable with it, then we write a policy so we know we can adhere to that policy. But
I see.
this formula is what I've used in all 5 hospitals where I've gone smoke free, and
That's
it's worked.
amazing.
Yeah.
So then you're not seeing, harmful effects of smoke in the OR anymore when these policies are in place, when you have this combination of devices and
Well,
localized exhaust.
anytime you change culture or practice, you got to monitor for compliance no matter what
Mhm.
service line you're in. So the ball doesn't stop at implementation.
Mhm.
You got to change that culture, because
Yeah.
let's say, not that I'm leaving, but if I left my institution and somebody did not keep the ball going with that culture or instill or hardwire, then they're going to go right back to start.
Yeah.
Somebody's not, a new person comes in, they're not going to open it up. And so you've got to change that practice. And a good example is when I was at Gwinnett Hospital System. I was there about 24 years. We were smoke free long before. I think we were pioneers in smoke. And they even got to the point where the surgeons that I was used to working with goes, where's my smoke evacuator? And now I haven't been at Gwinnett in almost 15 years, and they're back to they're back to start again because nobody is
Oh,
supporting the
no.
practice. So now they're going back because they got new doctors, new staff, that happens,
Yeah, yeah.
and
Right.
they're trying to implement a practice change that was already there over 25 years ago.
Mm.
Yeah.
Oh, that's a shame. Well, I'm glad that they're full circle coming
I
back,
know
so
it does. But we're hoping that it becomes just like ergonomics and
yeah,
PPE, that it becomes part of the practice of surgery, just like a
yeah.
bovie and a surgical table and instruments.
Yeah. It is so true, these ergonomic things and, these things in practice, we just have to identify them, and it's somebody has to say, I don't think this is healthy for the staff. I think that we probably need to change this. Like now we have hover mats that
Yep,
can, just glide 350-pound patients.
I
I can
know.
do that. Just,
The
I mean, think you need 3 people technically to do that, but it
that's
like makes them like 50 pounds,
Oh, yeah, and you couldn't move patients before, so it's kind of the same concept.
Yeah.
That was a culture change, and now a nurse or transporter wouldn't even begin to move a 350-pound patient without some type of moving device.
Right.
Yeah.
Right. That's very true. Going back to, I guess the accessibility of these devices to make, uh, procedure areas smoke free. I'm thinking of these times where endoscopy or GI has to do a road trip to a room. How accessible is it to bring those materials to, on a road trip per se?
That's a great question. You have different magnitudes of smoke that we said. You can have a little bit
Hmm.
exposure, but if you're supposed to all day long, 7 days a week, it's still cumulative. It doesn't matter. So when they're
Hmm.
going to intensive care, they use wall suction for GI. Okay, and
Mm,
the
okay.
thing about GI procedures, is contained in the colonoscope, which you're not gonna do, or the EGD scope. You can use
Gotcha.
something as simple as a point 0.1 inline filter connected to the wall and to the scope, to where it would
Mm.
capture it, and more times than not, you will not smell that smoke, and I know if you're an ICU nurse and they're doing a bug bee electrode or being coagulator to help control bleeding of ulcers
Mhm.
or whatever, you're gonna
Mhm.
smell it. But that will
Yeah.
keep down the smell significantly, and the importance is keeping it in a closed circuit. Now, what does that cost? If I show you, I think on the presentation you could see a little filter, it's about this big,
Mhm.
and it's clear, costs $10, and the limited life uses is once it changes color, you dispose of it. So
Oh,
you're
okay.
talking pennies on
Easy.
the dollar for the rooms, yes.
Right, and very efficient.
Yep.
Okay. What can we do as staff nurses to kind of implement if we are in a facility that doesn't seem like they have any practices in place? How can a staff nurse start to implement changes in their facility?
I think the voice of the nurse, in fact, that is our president's message, is advocacy this year. That's her
Mm.
theme. We have to advocate not only for each other, but the people who are in the room. And actually, smoke is not good for patients either, whether it's cumulative,
Yeah.
when it's in a laparoscopic or in their monitored anesthesia care delivery. So, to advocate for that is to understand and be knowledgeable about what our potential exposure rate is in something like this.
Mhm.
How I started in Emory, that was an easy conversion. Emory University Health System. And I just went straight to the safety committee, infection prevention. I showed them the data and they went, oh my gosh, we have to do this. Boom, it was done. So I
Yeah.
think you got to talk to the right people that are going to help
Mhm.
support you. You definitely, as a staff nurse, you've got to prove the financial analysis and how that will impact you.
Mhm.
I'll give you an example of the impact. It's probably less than $20,000 per year per department from my financial impact
Mm.
to make my team safe.
Right.
And I'll tell you, DNV and the OSHA alliance we have with ANMIT loved what we're doing to help protect staff. Today's world is we are kind of scarce with the nursing shortage and all. And
Mhm.
if now more than
Yeah.
ever, we have to take care of our team. So it's
Yeah.
advocacy is what it is.
Absolutely. Absolutely. That makes so much sense. And I know that we were talking a little bit about legislation. I mean, is there anything that we can do on that front to, help our states, kind of like facilitate on the legislative end?
Absolutely. Well, that's of course getting nurses that are passionate, and definitely from state to state there are. It's moving much faster. Where it was, it started in California 10 years ago, installed, and they went through OSHA. Oh, I think I'm
Mm.
trying to think what the acronym is for OSHA, Cal OSHA or something like that.
Mhm.
And then all of a sudden, it took a nurse who stood up with a lung transplant in Rhode Island to push the first bill that went into law. How we can get started is not only nurses that are passionate and educating our legislators and our senators, but
Yeah.
AORN, our Association of Perioperative Nurses, will help support states with lobbyists and the Georgia, like
Mm.
the Georgia Nurses Association. You're going to get involved there and bringing everybody together. And that's what we're doing in Georgia. But every
Okay.
state is replicating the same process and actually being very successful at it.
Yeah, I was gonna say, what states seem like they're pioneering this, front to for safer workplaces?
There is Colorado, and there is Rhode
Mm.
Island, there is Kentucky. I forgot about it. There is Illinois and there's Oregon. So basically, there's 5 states that have gone law with being smoke free with legislation. Who is coming up the back end now would be Georgia, is heavy on lobbying. Florida, Indiana,
Mm.
Maryland, New Jersey, Tennessee, Utah, Texas, and Washington. So I think once you get a lot of states that have converted,
Mhm.
another state's not going to want to harm our biggest commodity with
Oh, sure.
healthcare shortage. They're going to join right in. So it
Yeah.
is the pioneers that has already gotten the law passed that have made a difference. But our
Yeah.
association will support nurses and operating room staff in helping to get this be advocates for a smoke-free environment. Your
That's
hospitals are
wonderful.
smoke-free, right? Can't smoke in
Yeah.
the campus. Why
Right.
are we smoking in the operating room?
Right. Exactly. Yeah, I
Mhm.
didn't hear Virginia's name. We gotta work on that.
Yeah, I'm from Virginia. Shame on us, right?
Oh,
Yeah,
yeah, right?
yeah,
Well, now that it's uncovered, now that it's exposed, we gotta
yeah,
do something about it.
yeah, absolutely.
What do you think is in store for the future of the OR? Do you think that we will ever, move away from procedures that might produce surgical smoke in the future? Or are there, I know we were talking about how lasers are seem like they're kind of, you know, that the future in that way.
Yeah.
Speak to that. What do you think is in store for the OR for the future?
Well, obviously, the more minimally invasive approach to surgery, the better outcomes for the patient. It's
Mhm.
when minimally invasive procedures can give you a quality of clinical outcomes. You don't want to do it because
Mhm.
it's the latest technology.
Right.
But I'll give you an example, like our Mako robot, our intuitive robot for laparoscopy, and even image guided surgery, where we can actually see movement of instruments a millimeter from the site of target and not invade normal healthy tissue. I
Mm.
think we will always have some exposure. That's the nature of the beast.
Mhm.
I don't think we're anywhere near Dr. Spock. I still like old Star Trek where he waves a wand and
Scans
cures
everything, yeah.
everybody. But I think for less exposure to the staff is when we are not making large incisions and generating that smoke. But then we got to think about
Mm.
protecting our patient because it's going to be
Right.
cumulative in their belly and wherever we're working. But that's the key. It's a new
Mhm.
technology. Another would be telepresence, or not telemedicine, but telepresence, where you're working remotely
Mm.
and the patient will be at a point, not in mine or your generation, where they'll be in an operating room with the robot doing the case, and that exposure will be almost completely eliminated.
Mm.
There'll be
Okay.
micro robots where you can instill them. We know we can, in GI cases, swallow a capsule and follow it all the way down. We
Mhm.
a little easier in the GI tract to be able to do that. But I think minimally invasive technology will
Mhm.
make a difference in the outcome. They are even doing procedures not quite well adopted where we're pulling gallbladders out through an EGD scope. You would normally
Mm.
have to cut or do a laparoscopic gallbladder. They are
Wow.
doing
That's
common bile
amazing.
duct exploration and things all through that to
Oh,
the GI scope, EGD scopes.
I'm sure that OR is such a cool field in that way. You can be just, the top of innovation, all of that stuff like right when it comes out. That's some pretty great stuff.
Yeah, it is. It's exciting. Somebody said, "Well, you're on the wave of technology." Uh, if I'm on a wave, I've been on this wave 45 years.
It's a big one.
Okay, I don't think it's a
Yeah.
wave. It is
Yeah.
probably changing now more for this generation of nurses coming in than ever
Mm.
before. We have shortages. The technology boom is still there, where it's very complicated. Whether I don't know if you've seen that cartoon about the ICU nurse, and it's not really a cartoon. It's actually a really shot, and there's lines and all this stuff hanging, and some of the docs have even come back to me and said, "How do they figure all this stuff out?" I said, "I have no idea because I'm in the operating room." But it is a complex world we're living in, and we
Mhm.
are bombarded by technology, and we need to learn how to use it because it's making a difference in the outcome of our patients.
Yeah, it absolutely is. And it takes people being motivated and people like you
Yeah.
to, really pioneer and just get the word out there.
Mhm.
Things, need to be changed and figure out how to implement that so that all of us can be safe. So I
Yep.
really appreciate everything that you do for your community and for
Thank you.
AORN. And, I appreciate you coming and talking to us today about surgical smoke. And it was a it's an issue that I, as an ICU nurse, don't know a whole lot about, and I think that a lot of people are gonna be really, you know, their eyebrows are gonna raise for sure. I think that
Good.
it's gonna start a lot of good conversations that we need to have, so
Then I've done my job, right?
yes.
Yeah.
Yeah. Well, thank you so much for talking with us today, and
You're welcome, Maggie.
I hope this message passes on to a lot of people that need it to pass on to.
Yeah. Thank you. It's been an honor and a pleasure.
That brings us to the end of the show. Thanks for tuning in to Nursing Uncharted. To learn more about today's episode, make sure to explore the show notes at americanmobile.com/nursinguncharted. And don't forget to subscribe so you never miss a guest. If you're a nurse interested in traveling, visit americanmobile.com to explore the largest database of travel nursing jobs in the industry and the amazing benefits that American Mobile has to offer. Also, a special thanks to producer Jonathan Carey, assistant producers Katie Schraubman and Sam McKay, and Aidan Dykes for the music and editing. Until next time, take care of yourself.